Okay, let's go ahead and start. There may be some other folks that will trickle in. I sincerely hope they will. This presentation will be the Golden Hour Neonatal Resuscitation, and it is my pleasure to introduce Dr. Myra Wyckoff. Got it. Dr. Wyckoff really has a fascinating background, but she probably is the eminent authority on neonatal resuscitation today. She has contributed significantly to the literature. I remember one of her seminal papers demonstrated that routinely giving a bolus of normal saline to a depressed neonate is probably not a real good idea. It pushes the heart off the Starling curve, which is certainly no benefit to the baby. She is a professor of pediatrics at the University of Texas Southwestern Medical Center and director of newborn resuscitation services at Parkland Hospital. She has served on the American Academy of Pediatrics Neonatal Resuscitation Program Steering Committee since 2006. She's recently served a 4-year term as co-chair of that committee. Having previously served on that committee, I know the amount of work that the chair and the committee members undertake each year. She's currently the ILCOR liaison to the committee. ILCOR is the international body that governs resuscitation, both neonatal, pediatric, and adult. So she is a terribly important member of that committee. And she's also the AAP representative to the American Heart Association Emergency Cardiovascular Care Committee. So without further ado, Dr. Wyckoff.
Thank you. It's very nice to be here and share with you the topic that I love the very most, which is obviously neonatal resuscitation. So the title of the talk is The Golden Hour Neonatal Resuscitation, was what I was asked to speak on, but really I changed the title just a little bit because we're going to focus on the golden minutes in the delivery room itself. And so we have to go back and think about quite a bit of physiology. And so what is the role of the fetal lung in utero? Well, the fetal lung is not involved in gas exchange at all. The gas exchange is being done by the placenta. The lung is actually fluid-filled, and there's very high pulmonary vascular resistance, with only 10% of the right cardiac output actually going to the lungs. So the primary role of the fetal lung is actually growth and development. So at transition, there are some basic requirements that have to happen for gas exchange to start. We have to have initiation of ventilation and rapid fluid clearance. We have to establish air-filled functional residual capacity within the lung, and the baby's got to start spontaneously breathing. And then in addition to the ventilatory component, there's the perfusion component that is critical. We need a rapid reduction in the pulmonary vascular resistance with adequate cardiac output, with pulmonary perfusion, and there's one thing we're going to talk quite a bit about this afternoon, which is delaying cord clamping until the lung is inflated may have some real advantages in maintaining cardiac output. And so just as a reminder of how fluid-filled that lung can be, that top picture is a picture of a term baby being delivered in call in the actual amniotic sac. And you could just imagine floating around in that bag of water there and what has to happen very quickly. We have some really amazing physiology that's come to be understood in the last 10 years from Stuart Hooper's lab. Stuart is a PhD physiologist. He's not a neonatologist. And he is in Australia. And he has shown us with his transitional lamb model some amazing things. I'm going to show you a couple of video clips. Here's some actual pictures. So the fetal lung is preparing to remove fluid before birth, and changes in the direction of fluid flow within the lung and changes in the fetus's body position during labor help remove a little bit of the fluid, but most of the fluid is moved out of the lung by the baby's initial breaths and cry. And these breaths cause a pressure gradient that pushes the fluid from the airways into the surrounding lung tissue. And this image that I'm showing you here is a series of what's called phase contrast x-rays immediately after a rabbit pup is born. And on the far left, after the pup breathes, the lungs are filled with fluid. There's no air, and it looks rather dark. So in air contrast, phase contrast x-rays, as air enters, you see more white. Within 5 breaths, you see the fluid rapidly cleared into the surrounding interstitial tissue as it's replaced by air. And the newborn pup exhales against a partially closed glottis with crying or grunting and maintains some pressure within the lung, which helps to prevent the fluid from re-entering the airways from the surrounding tissue. So, with lung aeration, it's not only critical for gas exchange, the interesting thing is that that aeration and inflation of the lung is also responsible for initiating the cardiovascular changes at birth. Ventilation and aeration of the lung is the critical step that initiates the sequence of interdependent physiologic changes that enable the infant to transition to life independent of the placenta after birth. So with this rapid decrease in pulmonary vascular resistance, you get a rapid increase in pulmonary blood flow. And within minutes, the blood flow to the lung will increase 8 to 10-fold once you inflate the lung. Now, these mechanisms are very interesting. Some of it has to do with the mechanical distension of the lung. Some of it is due to increased oxygen, which is a vasodilator. There's other messengers that get involved, like nitric oxide and prostacyclin. And it is possible that there are also vagally mediated neural pathways. So one of the videos I want to show you is next. This shows the importance of establishing ventilation. So this is, again, a newborn rabbit pup who's been intubated and sedated prior to birth. A catheter was placed in the jugular vein. And before the lungs are aerated, the contrast, you're going to see it enter the right ventricle, and you'll see all of the contrast shunt across the PDA into the descending aorta, with very little of the blood ever entering the lungs. But about 10 seconds into the video, with only the right lower lobe, it looks like the left on the film, but the image is taken from the rabbit's back, only that right lower lobe gets inflated and dye is injected again. And this time you're going to see the dye perfuse both lungs. So I'm going to see if I can get the video to work. And now you're going to see increasing whiteness to the right lower lobe as you're inflating it, and then you see how the blood distribution completely changes. I think there's 2 really surprising things from that video. Even though only the right lower lobe was inflated, the pulmonary blood flow increases across the entire lung. The aeration had more than just a local effect. And the other amazing thing about this video, this was done with the lungs being inflated with 100% nitrogen, no oxygen. So oxygen is not required to lower the pulmonary vascular resistance. Now, in subsequent experiments, they used bilateral inflation and 21% oxygen, and that led to even greater blood flow. But still, just the local inflation and nitrogen worked. So ventilation, again, is the single most important and effective step in resuscitation of a compromised newborn. I thought we'd go through a little bit of a case to kind of keep some of these principles of resuscitation in our minds. So let's start with a 36-year-old primip mom who comes in with severe preeclampsia. Her membranes are intact. She has no history of trauma. She gets a dose of steroids, but that's been about an hour before you go to see her. And the bedside sono is supporting her 27-week gestational age dates. The baby is estimated to be around 820 grams. It's a female and a singleton. And the OB is telling the neonatal team that there's a category 2 fetal heart rate tracing and the baby's in a breech position. So they're considering doing a C-section under epidural anesthesia. This is our current algorithm for resuscitation for how we're going to approach a baby that might be in trouble for the North American continent. It's been adopted by the US and Canada as of 2017. I can tell you we're actively working on an update to the algorithm and the guidelines right now. Okay, so back to our case. Due to both the maternal and fetal condition, delivery's got to be imminent. And I'm showing you here our big level 4 Parkland Hospital. You can see in the picture on the left, there's old Parkland, and we have this brand new, shiny behemoth of a hospital that's looming behind it now, that's new Parkland. So we're not going to need to transfer the baby since we're at this level. We can't because the delivery is imminent, and we happen to be at a level 4 center. So the first step of the algorithm tells us that we need to do some quick antenatal counseling, and we need to have our team briefed and equipment check. So as far as the antenatal counseling goes, it is very important that we meet with the parents before the birth of such an extremely preterm baby. We want to have both the parents informed as well as the medical providers. And these discussions can be very difficult. We've got to convey a large amount of complex information pretty quickly. Oftentimes these parents are very stressed. One of the things that can be very helpful to you is to know both national and local outcome data and to understand the limitations of each. And if necessary, to consult with specialists at your regional referral center to obtain up-to-date information. For that antenatal counseling, it's best to consider multiple factors, not just the gestational age and estimated fetal weight, although those are very important, but also to consider the gender, whether the baby is a singleton or multiple, and whether or not the mother has received antenatal steroids. Now, ideally, both the obstetric provider and the neonatal provider should be present to talk to the parents. The perspectives between those two different services may differ, and such differences should be discussed before meeting with the parents so that the information is consistent. I'll give you an example of where you can get some national data. We have the United States ELBW outcome calculator. This was put together by the Neonatal Research Network under the leadership of John Tyson. This data is rather old. I would like to tell you very, very soon, and I do mean very, very soon, new updated data is going to be released within the next couple of weeks, so be on the lookout for that. But in this calculator, you can see the 5 different categories of information that we suggest you put in, and then you'll get a output of survival and survival without severe morbidity. The new data analysis that will be coming out has been put together by Matt Rasavi. Also, you should know your own local data. At Parkland, every year we update our survival statistics for the past 5 years. In the dark bars, you can see survival overall per gestational age, and in the blue bars are survival without severe illness. And so for our 27-weeker, if this was happening at Parkland, survival would be close to 90%, and survival without severe illness would be around 70%. Then we've got to get our team ready and our equipment. We want to have trained personnel that in my opinion, the best team would be a neonatologist, a nurse who's experienced in caring for such preterm babies, a respiratory therapist, and very importantly, a member of the team that we think nationally we need to be putting a lot more emphasis on is a recorder who is recording real time what the team is doing and the baby's responses. We got to think about thermal protection for this tiny baby. Do we have a warm environmental temperature in the room? Is the radiant warmer on? Do we have plastic wrap or thermal mattresses or warm humidified gas, some of the strategies that we'll talk about that can help stabilize the baby's temperature? Do we have a positive pressure device that can provide PEEP and CPAP? Do we have the right size blades and tubes if we have to actually intubate? There's not going to be any opportunity for use of a laryngeal mask in such a tiny baby. We have to adjust our oxygen concentration, starting concentration, which can be anywhere between room air and 30%. Do we have a pulse oximeter? And then we need to have a discussion with our OB team regarding plans for delayed cord clamping if the infant is active at delivery. So once the baby is born, we have to decide, are we doing delayed cord clamping or not? In 2015, the International Committee on Resuscitation reviewed the science behind delayed cord clamping. They looked for any evidence about outcomes such as mortality, severe IVH, any degree of IVH, hemodynamic stability, and neurodevelopment. At that time, they found 16 studies, 12 RCTs, which involved 691 babies, and 4 observational studies, which was another 811 babies. They did not find any difference in mortality or severe IVH, whether you did delayed cord clamping or immediate cord clamping. And there was absolutely no data available about neurodevelopment. But delayed cord clamping did seem to improve any degree of IVH, as well as hemodynamic stability. And here's the forest plot looking at for any degree of IVH. You can see the dark triangle at the bottom is not crossing the center line, and that is showing you that statistically there is benefit to delayed cord clamping in preventing any degree of IVH. So in 2015, the last guidelines release, we said that delayed cord clamping was suggested for 30 to 60 seconds for most preterm newborns who were showing some signs of vigor, meaning some respiratory effort, some tone or movement. We suggested that you place the baby skin to skin with mom, or the OB could securely hold the baby in a warm, dry towel or blanket, and that very preterm newborns such as ours may be wrapped in a warm blanket or in the polyethylene plastic wrap. But there should be no delay in cord clamping if the infant appeared lifeless or placental circulation was likely disrupted, cases like abruption or cord avulsion, bleeding placenta previa, or bleeding vasa previa, because those children were not included in any of the studies that were done. And that clearly this was going to take good communication and teamwork with the OB team. Now, since 2015, there have been 30 additional trials. This is the hot area within neonatal resuscitation. And there's now reports of an additional 3,000 babies. The largest and most influential is the trial that came out of Australia. It was a multi-center international trial, actually, done by Tarno Morty as the lead author. This trial included over 1,500 babies who were less than 30 weeks gestation, who were randomized to immediate versus delayed cord clamping. And the primary outcome was death or major morbidity, which they defined as severe brain injury on postnatal ultrasound, severe ROP, necrotizing enterocolitis, or late onset sepsis by 36 weeks postmenstrual age. Now, for the primary outcome, there was no difference. There was 37% of death or major morbidity in the delayed cord clamping group, as well as in the immediate cord clamping group. And you can see that the relative risk was 1, and the confidence interval crossed 1. But the impact of delayed cord clamping on death alone, when it was put into the meta-analysis with all the other trials that were available, suggests that actually delayed cord clamping may have some benefit towards preventing death. And then looking at IVH, when it was put into the meta-analysis of 19 different trials, that almost reaches statistical significance in delayed cord clamping, preventing any degree of IVH. It touches 1, but the whole confidence interval is actually on the side that is suggesting benefit. What about cord milking? I said that we weren't recommending delayed cord clamping for babies who were needing resuscitation, who were in a lot of trouble immediately upon birth. The cord milking idea is appealing because it can be done quickly so that resuscitation can commence quickly for babies who are not breathing. At the time of the last guidelines release, there had been only 200 babies randomized to either cord milking or immediate cord clamping in 4 very small randomized trials and 1 cohort study. And at the time, there'd only been 1 small study comparing cord milking to delayed cord clamping. We felt at that time that there just was not enough evidence yet to adopt this for routine use. So we said that you should not do this routinely for infants born at less than 29 weeks gestation, that it could be considered a reasonable alternative to immediate cord clamping to improve initial mean blood pressure, hematologic indices, and intracranial hemorrhage, but there was no evidence for improvement or safety in long-term outcomes. And we said, look, we'll be watching the evidence. If a bunch more trials come out, we'll redo the analysis and we'll see what it says. Since that time, there has been a small trial that got a lot of excitement. In 2015, Catheria did a randomized controlled trial comparing cord milking to delayed cord clamping for infants less than 32 weeks gestation. This was a 2-center pilot trial. It was powered for an outcome that you and I probably as clinicians don't care so much about. Just for sample size considerations, they were looking at superior vena cava flow differences, and the infants were delivered by cesarean and then randomly assigned to undergo the cord milking or delayed cord clamping. It was 154 babies. And here at the top, the umbilical cord milking is in the dashed line, and the delayed cord clamping is in the solid line. They looked at a bunch of different hematologic parameters, but the mean arterial pressure, there seemed to be some advantage to the cord milking group having better blood pressures after birth. They then followed these children out for long-term neurodevelopmental outcomes. They had about a 74% follow-up rate of the initial pilot trial participants. And it was very interesting that even in this small sample size, they reported significantly higher cognitive and language composite scores in the infants who had undergone umbilical cord milking. They also they were less likely to have a composite cognitive score of less than 85. Motor function was similar in both groups, and then there was no difference in the incidence of moderate to severe neurodevelopmental impairment, hearing or visual impairment, pulmonary morbidities, or rehospitalizations between the two groups. So maybe some suggestion of benefit. At the same time that this trial was going on, Stuart Hooper, whose video I showed you before, was trying to look at cord milking more carefully in a preterm lamb model that was undergoing transition. So these are preterm lambs who've been intubated and instrumented, and then they got randomized to different cord management strategies. And they measured umbilical, pulmonary, and cerebral blood flows, as well as arterial pressures. And they measured hemodynamic effects on the carotid artery blood pressure and blood flow. So I think what I really want you to take from this is on the left panel A, this is cord milking. And at the top, we have the carotid blood flow, and then in the middle, the carotid arterial blood pressure. And what do you see? It's going up and down in a sinusoidal pattern. What promotes bleeding in a preterm germinal matrix? Blood pressure swings. This got a lot of attention looking at this very important physiology. On the left is lambs that have undergone delayed cord clamping, where they've inflated the lung, they've got the animal breathing before they clamp the cord. What do you see there? No blood pressure swings. Very stable looking blood flow. So some clinical signs that might be a benefit, some animal signs that look very concerning. Catheria went on to design a large multinational randomized controlled trial for infants less than 32 weeks gestation, where they were comparing the cord milking, where they milked the cord 4 times versus delayed cord clamping of 60 seconds. And they had planned to study 1,500 babies. The trial was halted at 474 for safety concerns. There was no difference in the primary outcome of death or severe IVH for the entire study population. But here, with the data being shown with the delayed cord clamping in the middle column, or on the left side, and the umbilical cord milking on the right column, you can see, particularly down towards the bottom, severe IVH, grade 3 or 4 in the infants that were under 28 weeks gestation. So those babies that were most at risk seemed to have harm from the umbilical cord milking. And we would surmise that it's because of that physiology of having blood pressure swings as you milk and release, milk and release. So what about the delayed cord clamping for the non-vigorous baby who needs resuscitation? If we can't do cord milking, what is the best strategy for doing delayed cord clamping? We have a really interesting study from, again, Stuart Hooper's group. From the primary author was Bott, where they took these preterm lambs who were prenatally operated on at 123 days. They had catheters implanted, and then they delivered them at 126 days. And in the first group, the cord was clamped at delivery, and ventilation was delayed for 2 minutes. And then in the other group, they got ventilation first, so they inflated that lung before they clamped the cord. And then they focused on things like heart rate, left ventricular output, carotid artery pressure, and flow. And so in this experiment, the newborn lambs demonstrate that delayed cord clamping until the lungs are ventilated allowed for a smoother transition from fetal to newborn circulation. In the panel on the right, you see the immediate cord clamping is represented by filled-in circles, and cord clamping after ventilation is represented by the open circles. Now remember that nearly half of combined fetal cardiac output goes to the placenta and returns to the fetus through the umbilical vein. If you clamp the umbilical cord before those lungs are inflated, you lose a significant amount of preload or filling for both ventricles. And at the same time, you significantly increase the pressure head or the afterload on the left ventricle. And the result of immediate cord clamping is a spike in carotid artery pressure, seen in the top left panel, a decrease in the newborn's heart rate, the top right panel, a decrease in pulmonary blood flow, the bottom left panel, and a decrease in right ventricular output. If you wait until you clamp the umbilical cord until the lungs are inflated and pulmonary blood flow is established, you can prevent these effects. So we now have 3 national and international large trials going on looking at delaying cord clamping while resuscitation commences with ventilation with a mobile resuscitation trolley pulled up next to the mom. So you talk about needing to coordinate with your OB friends when you're a neonatologist. This is going to test us for sure. There's so many different ways of managing the cord that can be compared. The International Committee on Resuscitation has undertaken this systematic review looking at all of these different strategies and trying to help us as clinicians figure out which one is the absolute best to use. We're doing this in collaboration with the Cochrane collaboration, and this review will be finished within the next month and posted to the ilcor.org website where you can take a look at the conclusions. We're looking at term versus preterms, immediate cord clamping versus delayed cord clamping versus ventilation prior to clamping of the cord in those babies who are needing resuscitation. We're looking at the length of delay prior to clamping, immediate cord clamping versus the cord milking that we talked about, delayed cord clamping versus cord milking. There's a lot to look at to decide. Now let's get back to our baby. Our baby has been delivered and has some respiratory effort, but not great tone. They do attempt to do delayed cord clamping for at least 60 seconds, and then the infant is brought to the radiant warmer. And in our algorithm, the next steps are to warm and maintain normal temperature, position the airway, clear secretions if needed, and to dry and stimulate. So this issue of maintaining temperature is hugely important for us. We know that premature babies are at particular risk for hypothermia because of their immature epidermal barrier, which has high evaporative heat loss, the limited subcutaneous fat that they have, the increased surface area to weight ratio, ineffective non-shivering thermogenesis also plays a role. So in 2015, when ILCOR looked at the science regarding temperature stabilization, we found 36 different observational studies that demonstrated increased risk of mortality associated with hypothermia at admission. The hypothermic infants had increased morbidities as well, such as hypoglycemia, more respiratory distress, more intraventricular hemorrhage, and late onset sepsis. And so the conclusion was that we should try to maintain the temperature, we should monitor it in the delivery room and maintain it between 36.5 to 37.5 degrees Celsius after delivery. One of the studies that influenced that is the study that came out of the Neonatal Research Network, with the primary author being Abbott Laptook, where they looked at the admission temperature for infants who were under 29 weeks gestation and looked at the rates of admission temperature being hypothermic and outcomes. And you can see for the baby that we're talking about, a 27-weeker, at that time when the data was analyzed, about 40% of such babies would come into the unit cold. But the key thing that really should shake us up is that for every 1 degree Celsius decrease in admission temperature, the odds of late onset sepsis went up by 11%, and the odds of death increased by 28%. Now, that's an older cohort from the early 2000s. Since then, in NRP, we've put a lot of focus on trying to keep these babies warm and giving you strategies to use to do that. We reanalyzed the network data, and this was published in 2018. In the light bars, you see the data, the old data from 2002 to 2003, and in the darker gray bars, you see the more contemporary cohort. Now, you can see with the additional strategies that we've put into keeping babies warm, we have improved with less babies coming in very cold, and at the same time, we've actually increased the number of babies who get too warm. There are some new techniques, even since 2015, that have been found to be useful in keeping babies warm if you have a major problem at your hospital with hypothermic infants. Dr. Duryea, that was just speaking to you guys in the last hour, has done a trial at Parkland looking at the effects of the ambient temperature in the operating room. And she randomized the ORs to being either 20 degrees Celsius or closer to 23 degrees Celsius. And with that, she significantly cut down the number of babies who were hypothermic, both overall with a temperature less than 36.5 degrees Celsius, as well as those that had moderate to severe hypothermia. So that's one new strategy you could consider. In addition, there's been some randomized trials that have come out in the last couple of years showing that if you use warm humidified gases while you're ventilating these babies in the delivery room, that you can get a better temperature stabilization. In particular, the trial by McGrory showed that infants less than 30 weeks gestation who had the heated humidified gas came in with a rate of hypothermia of 27% compared to 43% when you were just using cold plain gas. So we know that it's such a problem that we may have to use a combination of strategies to keep these babies warm. For all newborns, we recommend that the environmental temperature of the room be at least 23 to 25 degrees Celsius. That's 77 degrees Fahrenheit. I doubt that very many of you in Texas keep your room that warm. I know that at my own hospital, people get very cranky when the OR is that warm. And we try to remind them that the only naked, wet person in the room is the baby, and that they need to think about that. We know that warm blankets for drying and wool hats and plastic hats can make a difference. The stocking net caps in randomized trials haven't shown to make a difference, and I think many of us still use stocking net caps. You might think about that. We want to make sure we have radiant warmers. The warm humidified gases are an option. And then for the preemie, like our 27-weeker, we want to have the polyethylene occlusive wrap and the heated sodium acetate mattress. All of these strategies have been shown in randomized trials to potentially be of benefit. You do need to monitor the temperature in the delivery room and adjust your interventions as needed because you can overdo it, and we want to avoid hyperthermia as well. So for our little baby, we don't skimp on those initial steps. We provide warmth. We have a warm room. We have the radiant warmer on. We have to lay the baby down on a thermal mattress. We put them in their plastic poncho and put the wool hat on their head. And then we have to position them in the open airway position. We clear the airway only if it's needed, if they're not breathing or if they're drowning in secretions. And then we offer the stimulation. Now, if the baby starts breathing and maintains a good heart rate, we shift over to the right side of the algorithm and we consider whether the baby needs CPAP to support the breathing that he's doing spontaneously. When we looked at ILCOR, there is a role for CPAP in the delivery room. If the heart rate and respiratory effort are adequate, but there is increased work of breathing, then CPAP can be considered. It helps to establish the functional residual capacity. You can deliver CPAP with a flow-inflating bag or a T-piece resuscitator, but not a self-inflating bag. So if you do a lot of little tiny babies, you're going to need to think about what equipment you have in your delivery room. This science behind the CPAP comes from 3 different randomized controlled trials involving 2,300 plus babies, which found that it does reduce death or BPD. There was no advantage for death alone, BPD alone, air leak, severe IVH, necrotizing enterocolitis, or ROP. But the treatment recommendation is that for spontaneously breathing preterm infants with respiratory distress who are requiring respiratory support in the delivery room, we suggest initial use of CPAP rather than the old school intubation and PPV. So for our baby, we put CPAP on right away, and we're attaching the pulse ox to the right hand. And then we're looking to see whether the baby has adequate respiratory effort and heart rate. In this case, our baby's heart rate is 80, and there's ineffective respiratory effort. So CPAP is not going to cut it. We cannot move to the right side of the algorithm. We have to move down on the left side of the algorithm, which is to start positive pressure ventilation. And in our case, we do that with a T-piece device. At Parkland, we usually have starting pressures of 25/5, and we may start with room air to 30% oxygen. So is one PPV device better than another for delivering PPV with PEEP? I want to show a video, and I may need the assistance in the back here to get this one going. This again goes from Stuart Hooper's lab. and he's delivered one of these preterm lambs, and he's starting PPV without PEEP. Now remember, if it shows up white, that's detecting air. So can we start the video? There's no PEEP here, and you see the white, the air is in the large airways, and you have some minimal inflation of the lung tissue, but then with each breath it collapses back. Okay, so now I want to advance to PPV with PEEP. We're going to have to deliver a couple of breaths for a few seconds before you start to see the recruitment, but let's do it with PEEP. Start the video, please. So they're delivering breaths. You see it in the airways. You start to see the lung tissue itself getting whiter and whiter. And now it's much more obviously white and inflated. So with PPV with PEEP is making a big impact on the development of the functional residual capacity that will keep the lung inflated even with exhalation. Okay? So which device can deliver PEEP best? In this study, investigators compared 3 commonly used resuscitation devices, the TPs, the self-inflating bag with a PEEP valve, and a flow-inflating bag. And they had 50 experienced participants who were asked to ventilate a mannequin using a face mask. And they said, hey, bag this mannequin with a pressure of 30/5 with a rate of 40 to 60 breaths per minute. And each participant gave 20 breaths with each device. The box plot shows the PEEP that was generated by each of the 3 devices. So the horizontal line within the box is the median, and then the box is the 25th and 75th percentile, and then the whiskers are the 5th and 95th percentile. The horizontal line at 5 centimeters of water indicates the target PEEP. So the T piece provided the most accurate and consistent PEEP, followed by the self-inflating bag with a PEEP valve, and then the flow-inflating bag was the worst. And I think if most of us know, the flow-inflating bag is pretty tough to use. It really takes an experienced RT to do that well, or an experienced neonatologist, but it's certainly not easy to learn to do. The flow-inflating bag had the most variation. So what about clinically? Is that true in the clinical world? Well, we have a randomized trial that suggests that the T-piece, when used in very low birth weight babies, those babies had fewer who had a heart rate that was less than 100 at 2 minutes, fewer who were intubated, and fewer with BPD and fewer days on oxygen. And then very recently, we have a very large cohort study of close to 2,000 very low birth weight babies where the T-piece was associated with a greater chance of survival without major morbidity. So I do think it has some implications that the T-piece has some real advantages if you're dealing with a preterm baby. What about the oxygen? Very quickly, for infants who are less than 35 weeks, we recommend at the ILCOR level, looking at the science, that you use a low oxygen concentration rather than high. It is a weak recommendation with very low certainty evidence. This comes from 10 different randomized controlled trials and 4 observational studies. This meta-analysis was just published this past November, and Welsford is the primary author if you want to look at it in more detail. So it's not that the evidence showed that the room air was way better, but it showed that there was no harm compared to starting with high, and we value not exposing the preterm newborn to additional oxygen without proven benefit for critical or important outcomes. We're trying to balance the need to give sufficient oxygen to correct the hypoxemic state and the desire to avoid excessive oxygen exposure. And our goal is to titrate the oxygen amount to achieve a target SAT, and the target SAT is the same as the median for term babies. So in our baby, the heart rate quickly rises, the oxygen gets adjusted to meet the goal SATs, we are able to transition to CPAP, and we prepare for transport. And in conclusion, an immense amount of complex decisions and tasks has to be accomplished in the short period of time following the birth of an extremely low birth weight infant. A standardized approach using the best possible evidence should be used. We have to allow for individual variation in response of the neonate, but our goal is to provide the least invasive support needed, but we must be prepared for the worst. And this takes really strong communication, teamwork, medical knowledge, and clinical skills. Thank you.
Given that we started a little late, I think we have time for one or two questions. There are two microphones, one on either side of the room, if anyone would like to take advantage. You got 30 seconds before I shut it down.
I see a hand.
Oh, there's a hand.
Is there any differentiation between delayed cord clamping for 30 seconds or 60 seconds?
So, there is not a lot of data comparing those two different points, but in this complex systematic review that ILCOR is doing currently with Cochrane, it is one of the things that they're looking for that evidence to compare. I can't give you the answer yet, but in the next month, we'll have it.
1 month, okay, gotcha.
One last question.
I'm from a rural area, and so my question really is for us and those of us that do the resuscitations, are there any, what do you have a good practice intubation, either dummy or software program, or what's the most up-to-date thing that we use now for that?
So the American Academy of Pediatrics NRP Steering Committee has partnered with industry to try to develop the best possible micro-preemie simulator that we can. And all of our efforts were really focused on trying to get the airway right. Make it look realistic, make it a realistic depth, make it a realistic difficulty in that you have to have the simulator in the right open airway position or you can't get the tube in. And that simulator, I can talk to you offline later, but there is a good tool out there that we've worked hard at the Academy to partner to meet the NRP goals with.
Okay, thank you.
Okay. Thank you all for attending. We do have a short break until 3:15 when the